And this meeting is being recorded today. It won't be being shared currently, but more so used as a point of reference. I'll introduce our panelists, our wonderful panelists, and then I will hand over to Dr. Alrubaie. So our first panelist is Professor Robert Booy. He's chairman of Vaccination Coalition, a pediatrician and an epidemiologist. And he will be talking to vaccination in children aged 12 to 15 and speaking to the latest data on safety and efficacy of vaccinations and post-vaccination. And our second panelist is Associate Professor Alrubaie, OEM. He's a senior gastroenterologist, a therapeutic endoscopist and general physician. And he will be speaking to the Delta, the specific variants of COVID-19, long COVID and vaccines in general, and the types of vaccines. We have Dr. Fidel Mettis, the consultant and a respiratory physician at Westmead Hospital, and he will be covering the management of COVID-19 both at home and in hospital. And lastly, we have Dr. Jamal Rifi, and he's a general practitioner and a vaccine expert. And we'll be speaking to vaccination, supply and logistics, and the mobile centres and pop-ups, and the difficulties facing that GPs generally are currently facing. So welcome to all our panellists and all our participants today. If you do have any questions, please can you either wait until the end of the session where we'll have an open Q&A, or feel free to pop those in the chat, and I will make note of those, and we'll have a facilitated Q&A at the end. Dr. Ahmad, if you'd like to say any additional words.
Thanks. Thank you very much, Rachel. I would like to start by passing my thanks and great appreciation to Western Sydney Migrant Resource Centre, and in particularly to Rachel and Nadia for their great efforts in helping in hosting this event, and also in all the preparation prior to. I would like also to thank our distinguished guest, Prof. Rob Booy, Dr. Fidel Mettis, and Dr. Jamal Rifi. I would like also to mention that this event is part of our corona vaccination campaign, which started late April and going on through efforts of different levels, including webinars and meetings. And I would like to mention that this meeting and all events of this campaign is not funded by the government or by any formal body. So it's a purely volunteer effort, mainly to support our community and our colleague clinician and general practitioner. Thank you.
Thank you, Doctor. So the first presentation today, that's from Dr. Robert Booy, and Dr. can I ask you to unmute, and yeah, it's over to you. Thank you.
Magic. Okay, it's a tremendous pleasure to be with you. I'll try to be clear and brief. I've got a lot of slides. I won't get you to read them all. I'll just show you the most important ones. As you know, I'm a children's doctor, and I've been doing epidemiology for 30 years as well. I'm an academic and a clinician, especially interested in infectious diseases and vaccines. So I will focus on teenagers today, but there will be broader relevance to older adults in my talk. I hope you can hear me. I'm waving. Professor Ahmad, can you hear me? Yes, good. So I'll move on. I gave this talk, a similar talk, to intensive care at the Children's Hospital at Westmead last week. So when I get to the intensive care slides, I'll slip over them quickly. we're currently shooting our way out of trouble. We're doing a fantastic job in Sydney, especially in southwest and western Sydney. My hat goes out to you, my heart goes out to you. You're doing a great job. We're in New South Wales getting over 700,000 doses into arms every week. We're up to pretty much 80% first dose. And the last 5 days, the daily numbers look really good, the 7-day moving average. There's still more than 200 people in intensive care and over 100 on ventilators. So this is a big problem for the hospitals. It's a big problem for general practice. It's a big challenge for pharmacy. Australia has had only 1,100 deaths, about 250 total in New South Wales. Compare that to the UK and the US. They've done much more poorly than we have. They have hundreds of thousands of deaths. But children, not one child has died of COVID. So we know that it's very different, that they've got an immune system which helps them to fight COVID. And Indigenous, well, I do a radio slot every second morning with Western New South Wales. There are 3 Indigenous people who've died, and there are half a dozen in intensive care. So it's a growing problem in the far west, as well as in Sydney as well. So what about 12 to 15-year-olds? 100,000 children are born every year in New South Wales. That compares with 4 million in the United States. And what we have, very importantly, from the United States is at least 10 million children who are teenagers and safely vaccinated. So that is something you can tell your patients, your parents, that this vaccine has not been tested just in a few thousand. It's actually been safety followed in 10 million. We do know that there's a common problem in young adolescent males, especially teenagers, especially after the second dose. Virtually no deaths, however, and that problem is myocarditis. I'll talk more about that as we go on. And I just want to remind everybody that the risk of a serious clot is 10 times higher with COVID disease than AstraZeneca vaccine. The risk of myocarditis is 5 times higher with disease than with vaccination. Now, why do we want to vaccinate children when they're so well, when they only get a mild cold and they don't get very sick? Well, the only way to prevent the rare serious cases is universal vaccination. So about half of the deaths that are seen in the UK or the US in children have been well. We don't know why they got so sick and died. Half of them had cerebral palsy, Down syndrome, chronic heart or chronic lung trouble. So those ones are prioritized. If you have a 12 to 15-year-old with a chronic medical problem, vaccinate them first. But as we do for influenza and for measles, we vaccinate everyone to get control in the community. And especially we want to get kids back to school. We want to get teenagers and younger children attending school for their social, their physical, their mental, and their educational health. I'm going to pass over. I won't talk about that. Now, the world situation. Right now, in Australia, we're doing super well. We've got over 70% of people first dosed, 50% 2 doses in New South Wales. Fantastic. But our near neighbours in the Pacific, in Indonesia, in Southeast Asia, in Africa, they're not being vaccinated. Less than 5% of most countries have had vaccination. Australia, it's 50% plus. United Kingdom, it's 60, 70, 80%. United States, 70%. All the rich people are getting vaccine and the poorer countries aren't, and we need to do something about it. And one of the facilities is a COVID facility through UNICEF is giving vaccine to countries. They're aiming for 10%. That's not good enough. We need to get 20, 30%, even better. And for our own good, and for altruistic reasons, because we care about fellow humans, where the virus is mutating is where there are most cases. And Indonesia has had so many hundreds of thousands of cases almost on a daily basis. So they need vaccine far more urgently than we do. So only in August, there were 700 children in Indonesia who died. I looked it up today, it's nearer 1,500 now. No children have died in Australia, 1,500 just in Indonesia. They need vaccination, they need better nutrition, they need treatment for co-infection, they need oxygen, they need intensive care. I'm part of the Immunisation Coalition, and we ask everyone who's had a free vaccine to pay the UNICEF a donation. So if you want to, you can look up Immunisation Coalition, Google that, and that can point you to 100% donation place. I won't go into that. So Australia has about 80,000 cases. New South Wales is the most active cases, and we're vaccinating so rapidly. 10% of the population are getting a jab in New South Wales every week. But we have 10,000 weekly cases in New South Wales. So the challenge has been met by general practice and pharmacy, especially in really ramping up. And you don't need me to tell you what a great job you've done. So I'm not going to talk more than a moment about the Delta variant. There is some research, but only in mice, which suggests that the immunity from vaccine and from disease can be escaped by just 4 mutations, 4 common mutations in the virus. But I'll leave that to my colleague to go into details. And this research is only in mice, and mice tell fibs, they tell lies. They're not the same as humans. So I won't go into any more than that. I'll leave that to colleagues. Influenza, there's a thing called gain of function where you can make the influenza more transmissible and more severe. And I told our intensive care colleagues about the experiments done already 10 years ago in influenza. And some people worry that gain of function has happened with the coronavirus. We're not sure about that, probably not. So I'll leave that again too. Although we know that coronavirus is a zoonosis, it's come from bats, we don't know the animal which was the intermediate host. So again, I'm not going to go into detail. We do, however, speculate that there are a whole bunch of prior coronavirus infections like SARS-CoV-1, which came into humans in 2002. And there's another one called NL63, which came into humans around 1350. So that's 700 years ago. And OC43 might have been the cause of the Russian flu in 1889. So coronaviruses may have caused global pandemics before, a century ago, 130 years ago, or perhaps 600 or 700 years ago. And again, I'm going to save you, there's alpha, beta, gamma, and delta. Suffice to say that I like to remember them by saying alpha is B117, like the new James Bond, and beta is so clever that it beats our vaccination, and it's the least one, it's the one that's least well protected. So I say you better get a better booster for beta. Fortunately, beta is going away anyway, so don't worry about it. Delta is the main concern, B1617, and I call it the teenage mutant ninja twosome. Okay, I won't talk about more mutations, I'll leave that to colleagues. Now I'm going to talk about the vaccines. I'm going to concentrate on Pfizer, because that's the main one being given to young people. I'm going to talk about safety and effectiveness, both in the trials and post-licensure in usage in the United States. I'm going to talk about side effects within a few days, like myocarditis, acute events like anaphylaxis, and a little bit of advice after vaccinating children. We know that there's TGA approval of Pfizer, and that's for 12 to 15-year-olds. And ATAGI has recommended, only in the last week or so, that it be given to children from 12 years of age and above. Healthy children have been included now. Now, it's interesting, see that third point, a 2-dose schedule using Pfizer. I say it's interesting because the UK is only using 1 dose. They're saying that the immune response is so strong in teenagers, and I'll show it to you in a slide in a minute. The immune response is so strong that 1 dose might be enough. And that could be important. It's not the recommendation of ATAGI. I'm just comparing us with the United Kingdom. Could be important though, because the myocarditis occurs mostly in young men after their 2nd dose. So there'll be more discussion about this. I'm not telling you to only give one dose. I'm just saying there'll be more discussion. And Spikevax or Moderna is coming very soon too, especially in pharmacy. So what are the priorities? Well, first of all, any child 6, 12 to 15 with a medical problem, and I've listed some of them: heart disease, lung disease, bad asthma, cerebral palsy, they should be vaccinated first. Also, Indigenous children, Aboriginal and Torres Strait Islanders, and anyone in a remote community, the Far West, for example. And what are the conditions? I've already mentioned some, but immunocompromising conditions are important, and that includes various cancers that children get, and solid organ transplant and bone marrow transplant. It's always when you've got a complicated patient, involve the specialist, of course. What are the other conditions? Well, neurological, complex cardiac, obesity, and complex chronic disease. What's the hospitalization rate in children? It's tiny, and the percentage admitted to intensive care in children under 10 is very small. And if you look across the top row of 500 cases in the United States, there were none admitted to ICU in an earlier study. In teenagers 10 to 19, it was 0.6% admitted to ICU. So what about a clinical trial? Well, I'll show you just a little bit of data, and I'll concentrate on the headlines. This was published just 2 months ago. It's on the safety and immunogenicity and efficacy of Pfizer vaccine. And if you look to the bottom table, 12 to 15-year-olds on the bottom left and 16 to 25-year-olds, look at that. The immune response is best in 12 to 15-year-olds. And the take-home message is that you are at your immunological peak, your very best as a teenager. And it's all downhill from there. Your immunity actually is strongest at about the age of 15, and it goes down from there. So it's still good when you're a young adult and an older adult. It's just not as good. So if we look at efficacy, prevention of disease, it's very high. This is a study with just 2,000 young people, 12 to 15-year-olds, and there was 100% efficacy against disease. Very impressive. What about if we look at the side effects? Well, the most interesting thing is that you get pain and fever. Pain at the injection site is very common, slightly more common after the first jab, but you look at the second jab, it's still very high. So pain and fever are the key things after the first or the second jab, but more after the first, but it's very similar. With AstraZeneca, you're much more likely to get side effects after the first. You would know that from treating patients. And the second dose is less reactogenic. If you look more widely, things like fatigue, in the top row is the first dose, and in the bottom row it's the second dose. So fatigue about 60% in people who are teenagers or young adults, and then in placebo you can see the background rate to the right. So the first two are active, and the next two 25% or 40%. Those are placebo. So what else? Headache is common, and chills are common, and muscle aches. You've learnt all this already from patients, but this is what the studies show, the most common being fatigue and headache. So this has just been published from America. It's looking at safety in teenagers for the first 7 months. And I guess this is a complicated slide, so let's look at the very top box, dose 1 and dose 2. Any injection site reaction around 60%. So, and that is especially pain. If you look at the next box down with fatigue, fever, and headache, you can see that fatigue and headache are about 30% after dose 1 and 50% after dose 2. So I'll keep going. I'm going to run out of time, so I'll try and keep up to date. Vaccination in children. What are the most common reactions reported in the first week? Well, I've said it already, injection site pain and fatigue, headache, and muscle ache. But look at whether it occurs in a 12 to 15-year-old or a 16 to 25. The 12 to 15-year-olds seem to get fewer symptoms. So although they get a better immune reaction, they get a stronger antibody response, they less commonly get injection site pain or fatigue and headache. So that's interesting, isn't it? we're doing safety surveillance in Australia. Already 2.5 million safety surveys have been recorded. So suffice to say, we're doing a good job of checking for safety. I'm not going to go into those details. I'm now going to talk about myocarditis, inflammation of the heart muscle. The symptoms might be shortness of breath, especially with exercise or lying down, fatigue, heart palpitations, chest pain. So if patients get this, you can actually warn them to look for this. The TGA encourages people to report it so that we can know exactly what's happening to our teenagers being vaccinated. So there's very good guidance available that you can look up on the net about COVID vaccination in teenagers. But if you want to do your own search for ATAGI, A-T-A-G-I, and CSANZ, C-S-A-N-Z, the Cardiac Society of Australia and New Zealand. So here's some of the fine detail. Most children who have a pre-existing cardiac problem can still have a Pfizer vaccine. So most children are not precluded. So if they've got a history of having had in the past, more than 6 months ago, myocarditis or endocarditis or pericarditis, they can, or coronary heart disease, not very common in children. But if you've had any of those things and it's stable, then you can be vaccinated. Looking on the right-hand side, what if there's a condition that occurred within the last 6 months? Acute rheumatic fever or cardiomyopathy. Then you should speak to a cardiac specialist to get some help and advice. So when does this occur? Well, it's really interesting that it's much more common in teenagers than even in the 20s. And it's much more common after dose 2. So look at the red bars. They're in 16, 18, 20-year-olds, very high. And then that's the second dose. Dose 1 is about a quarter the number of cases. So that's one of the reasons why some people in the UK are only giving 1 dose. It can occur up to a month or so, but that may be the background rate and not anything to do with vaccine. So almost all of it occurs within 5 or 6 days. So here you see, days from vaccination to symptom onset, almost all cases have occurred by 5 days. And in girls, it's much less common than boys, about 1/5 as common. So there's a lot of numbers here, but if you just look at the top row, 12 to 17-year-olds, the observed number of cases was 20 in girls, and it was 130 in boys, when both were expected to be only 5 or 10. So that's very interesting. Carrying on, cases reported in the United States to their safety system called VAERS, V-A-E-R-S, Vaccine Adverse Events Reporting Scheme. And if you look at the red box, reporting rate in females per million doses, about 5 to 10. But if you look after the second dose in males, 50 to 60. So you can see that that's where the issue lies. I'm not going to show you a complicated slide like the next one. What I do want to say is that virtually all of these settle within a week or two. They might need admission for a day or two, and generally that means doing an ECG and a troponin and a chest X-ray and being looked at in a hospital just to ensure that there isn't another problem happening. You can look up this. This is the approach. There's no time to go over it now, but it includes doing chest X-rays and echocardiograms and troponins. But that's done in hospital, and I won't bore you with that detail. What does ATAGI say? Well, you can look it up. But if someone has experienced myocarditis or pericarditis that may well be related to the vaccine, they should see a cardiologist for proper assessment. And that's the simple thing to do. And don't give a second dose of vaccine until the cardiologist has said what's going on. And if it is related to Pfizer, perhaps there is an alternate vaccine that you can give. I'm nearly done. So take-home messages. The surveillance in the United States has found quite a lot of myocarditis, perhaps as many as 1 in 15,000 adolescent males after the second dose, 1 in 15,000, especially in teenagers, more frequently in males, especially after the second dose and within 5 to 7 days of vaccination. So when you're preparing a teenager to get vaccinated, there's a few simple things. I don't want to teach you to suck eggs, or to have your breakfast. just read the notes. You can see logical, practical advice there, including some relaxation techniques, especially deep breathing. I won't bore you with that. Anaphylaxis may occur 1 in 100,000, not very common. Much more common to get a faint or an acute stress response. And I don't think we've got time for me to go into those details. You can look those up. Essentially, if it's fainting, there's a pallor. If there's anaphylaxis, there's more likely to be a pruritus, a skin itchiness. Cool, clammy skin if it's fainting, urticaria and erythema if it's anaphylaxis. Other comparisons you can make yourself and you can look up. The dose, if you don't know, of adrenaline 1 in 1,000 is 0.4 to 0.5 of a mil for teenagers. And it's only going to occur 1 in 100,000, so you'll probably never see it. You can go and see other doctors on the internet. This is Paul Offit, who runs an advice service in the United States from Philadelphia. He answered the question, do COVID vaccines cause infertility? Well, you could have seen me answer that question on television this morning, because I did that on Sunrise at 7:20. So I'm nearly done. There's lots of good resources. The National Centre is very good. And you can look up NCIRS and get lots of important information, including a glossary on the far right-hand side in light blue, a glossary of medical terminology, which helps people to understand all the fancy words and puts it into other languages. So really lovely to talk to you. I'm sorry to be so rushed. I won't talk about the medical contraindications of AstraZeneca and the issue around thrombocytopenia and thrombosis. You know that story well. I'm happy to come back to it in the questions, however, because I know I'm out of time. So thank you so much. And definitely, if you want to go to these issues in the questions, I'm very happy to entertain that. And I'll stop now and let other people have a chance. Thank you so much.
Thank you so much, Dr. Booy. That was really informative, speaking to the safety profile and side effects as well. So please just reminding everyone, if you have any questions, and we'll do that at the end of the next few panelists. And so, Dr. Ahmad, I'll hand over to you for the next session, and I'll ask you to unmute and share your screen, and it's over to you.
Well, I thought it was shared there. Okay, this is here. Okay, is it full?
Yes.
Okay, thanks, Prof. Booy, for this excellent and very refreshing presentation. I think the initial phase of this pandemic was dominated by the Wuhan version of Corona. And over the last year, we get used to certain roles of game or dealing with this virus and the fight against this virus. So we were familiar with the rate of transmission, which is not huge. We were familiar with the spectrum of severity. We were talking always about the 80% mild, 15% moderate, and 5% severe. And we were talking about a pandemic which mainly affecting elderly, both in terms of the severity, in terms of the mortality, and in terms of the number of cases. But these rules have changed dramatically with the appearance of variants. Now, mutation and appearance of variant is part of the natural history of all viruses, including our flu virus. And there are more than 4,000 mutations happened over this period of time. The pandemic, the majority of them were trivial, mild. We call them the passengers, not affecting the behavior and the strength of the virus. But some of them, they can help the virus. They are favorable mutations which help in the survival and in the reproduction and proliferation. Now, I think all of you know there are many of them right now, and there are at least 13 of these mutations, and these were classified by the CDC, the Center of Disease Control and Prevention, and by WHO as the variants of concern, and there are 4 of them. Prof. Booy mentioned the alpha, beta, gamma, and delta. And there are these viruses or these variants. We have the alpha variant, which appeared initially in November, October last year in the United Kingdom with a total of 23 mutations. I wouldn't go into much details. I think there are some clinical aspect of things we need to focus more on. The beta variant, which appeared in South Africa late last year in December with a 21 mutation, and the gamma variant, which appeared in the Brazil with 17 mutation, and it appears also late last year. And the worst is the delta, in spite of having just 13, but some of these mutations are much more favorable for the virus. Now, the other type of the variants are the one classified as the variant of interest, because they are not as transmissible as the other 4, and they are not causing a severe form of disease like the other 4. They are mainly, this interest is mainly around the ability for the immunity escape, so that they can resist our immunity and the vaccine more than the standard virus. So the epsilon appeared in the state, the eta in United Kingdom and Nigeria, iota in states, kappa in India, it appeared together with the delta, theta in the Philippines, and zeta in Brazil. But lately, the WHO downgraded both theta and zeta, and they removed them from the list of variants of interest because of the limited number of the cases. Now, I think the other 2 variants, there's a lot of concern about them, is the lambda variant, which appeared in Peru last year. Actually, it appeared in around July, August, and found that it can cause more severe disease with the mortality rate of about 9.2, compared with 2% related to the Wuhan version of the virus. Luckily, this virus is still in Peru and Latin America, although during the Japan Olympic, they were talking about few cases entered Japan, but we don't know yet the exact number of the total cases there. Now, the other variant, which is more recently talked about, is the new corona, new variant, which is also classified as a variant of interest. It appears in Colombia, but luckily it's limited even in that country with around 10%. Although more recently there are around 40 countries involved with this virus. The main issue with this variant is the immune escape and the resistance to the immune reactions. Now, comparing the main variants, you can see here that Delta has the highest transmissibility and the highest ability to immune escape, to escape the immune reaction and also the vaccine effect. These are the comparison between the main variant. Now, more recently, and in India, where Delta appeared, we have the Delta plus variant with an extra mutation, which makes more contagious, causing more severe cases, and also more ability to resist the immune system. Now, I'll stop here at the Delta because Delta is dominating the current phase of the pandemic worldwide, not only in Australia, worldwide. The latest number from states that 99% of cases of corona are caused by Delta. Even in UK, where Alpha variant appeared, Delta dominated, and they have the majority of their cases from Delta, like in Europe also. So it is the dominating variant right now. then the danger and the risk of the Delta variant, first in its high transmissibility. It is higher, more contagious than the Alpha variant by 50 to 60%. And Alpha variant is more contagious than the Wuhan version by around 50%. So it is very contagious. The reason why the viral load in Delta infection is very high, is more than 1,000 times the viral load of the ordinary or the initial version there. The shedding period is longer. It lasts up to 18 or 19 days versus 12 with the old version. And in immunocompromised patients, for any reason, chronic disease or immunosuppression, this can extend up to 20 days. It has a shorter incubation period. Delta can cause more severe. I think this transmissibility was translated in the number of cases among young people. And if you go to the latest numbers there, we have among the young people around 70% of the cases were younger than 40, more than 50, 54% younger than 30, and around a third of them younger than 19, with around 9.5 less than 10 years. So that's due to the transmissibility, the high transmissibility. Now, Delta can cause even more severe and dangerous cases. And this is also related to its immunity escape. We have more cases in ICU and hospital than the previous strain, the original strain. And in many studies in Canada, Singapore, and lately in Scotland, it showed that the rate of admission, the rate of ICU admission is double the rate of the Alpha variant, where it was dominating in UK. Now, even in the initial presentation, while we were dealing with the flu-like illness in the initial phase, now we are dealing with almost a cold, a bad cold, with headache, sore throat, and runny nose as the presenting symptoms. Now, it also still attacking the respiratory system as the primary system, with the shortness of breath, chest pain, and with respiratory failure in severe cases. But we're seeing more cardiac involvement with the Delta virus, both in the form of myocarditis, pericarditis. And I will stop here into a latest study from USA, which have the number of pericarditis and myocarditis in young people. You can see 450 cases in million among young people. Compare them with the one in 115, as Prof. mentioned, 213 in each million in young females. So you see it's much higher in number, and it caused much more severe compared with the vaccine, with the pericarditis myocarditis related to the vaccine, as Prof mentioned, because the majority of cases can end with the myocardial damage, failure, and death. Now, cardiac arrhythmias also are common in the Delta version, with atrial fibrillation and the AV block. We start to see more neurological complications, including stroke, encephalitis, peripheral neuritis, so both central and peripheral nervous system. We start definitely seeing more gastrointestinal complications with diarrhea, abdominal pain, nausea, vomiting, and deranged liver function, and also pancreatic function, more than the original strain. Now, I stop here and I go through long COVID. Now, as a clinician, general practitioner in general, I think we will deal more and more with long COVID. And that's why the importance of focusing on it. Now, long COVID defined as any symptoms which continue or arise more than 4 weeks after the infection. Now, the background for this syndrome, because there are more than 50 symptoms possible in relation to long COVID, is the ACE2 receptors or enzyme right now. So you know this original mechanism of the virus invading our cells using the spike as a key to unlock the lock. The lock is virtually the angiotensin converting enzyme 2. It's an enzyme on the surface, and by unlocking this, the virus can introduce itself into the cell and start proliferating. Now, this ACE2 is expressed in variable levels in different parts of our body and system. It's virtually all systems, they have this. That's why long COVID talks about around 50 type of symptoms or clinical manifestation. Now, the most common one is the fatigue. More than 58%, they have fatigue together with myalgia and sleeping disturbances, similar to what we get in the chronic fatigue syndrome, which we see frequently, by the way, in relation to other viruses like cytomegalovirus, Epstein-Barr virus, herpes virus, and enterovirus. And there is a talk right now to classify corona as part of the chronic fatigue syndrome. Now, respiratory features as a long COVID, like dyspnea in almost quarter, cough in 19%, and the main mechanism is either the effect of the cytokines or the thromboembolism. People with lung disease, with the old age, with the long hospital staying are at more risk. Now, the cardiovascular abnormalities, chest pain can continue for a period of at least 60 to 70 days, chest pain in about 21%. Arrhythmia is another feature of this, particularly this atypical type of arrhythmia. So atrial fibrillation can occur, tachycardia, sinus tachycardia can occur, but this postural orthostatic tachycardia syndrome, which tend to occur on standing, only on standing, with the features of tiredness and heart racing, etc. It is related to long COVID. And the thought is that it's mostly coming through the virus affecting the autonomic nervous system. Cognitive changes and mental disturbances are also common. Headache, 44%, attention disorder and brain fog for around 25, anosmia, 21, neuropathy, stroke, Guillain-Barré, and even early dementia. It's reported as one of the manifestations of long COVID. Psychiatric condition, anxiety, depression, OCD, etc., also are common. The possible mechanism is a variety of either a direct effect of the virus or the cytokine effect, in addition to changes on the permeability of the blood-brain barrier, in addition to the effect of deconditioning, staying in hospital for a long period of time, plus the effect of quarantine, isolation, and social distancing can impact with the mental manifestation. I will pass a few minutes on the general view of the vaccines available. And I will go through just the 4 main groups. The first main group is the mRNA vaccine, everyone knows. Now, I would like to stress that although this is the first time this technology is used for vaccination, but it is well recognized and used in many of the other cases, immunological disorders, cancers, and also some infectious diseases. So this is not a new technology, but we are dealing with the first time of using this technology in the production of vaccines. I'll pass quickly. The 2 representative are the Pfizer's and Moderna, and that's why they are brothers, and the effect, efficacy, and even the safety profile are comparable because of this technology. The second technology is the subunit vaccine, where the S protein is used using the nanotechnology to deliver the message to the immune system to react on producing antibodies against the S protein. And because this reaction is usually not severe or not strong, an adjuvant is used to enhance the immune response. The only representative of this category is the Novavax, the American Novavax vaccine. The third category is the viral vector vaccine, which is the vaccines which use a harmless virus, like the adenovirus, which is the common cold virus, as a vector to transmit the gene to our cells. And the representative are Oxford and its version in India, the Covishield vaccine. This is AstraZeneca and the Indian producing the Indian version of AstraZeneca. Also, the Johnson & Johnson, the American, and the Russian Sputnik V. These are all from this technology. And the last group is the inactivated vaccines, which virtually use the SARS vaccine itself, the SARS virus itself, after inactivated the virus and inactivated all the genetic material of it using beta-propiolactone, in addition to adjuvant. They use adjuvant because the stimulation of the immune system is not enough by this one. And the representative are three: the Sinovac, the Chinese Sinopharm, and the Indian Covaxin. I'll stop here. Thank you very much.
Thank you so much, Doctor. We're going to move straight to our next presenter for Dr. Mettis. And you're already sharing, so I'll hand over to you. You're on mute. There we go.
Thanks, Rachel. Thanks for letting me to have a talk about the management of COVID-19, which we are facing to a great deal at Westmead Hospital over the last few weeks. You know, being a part of the members of the COVID team there, we actually saw a lot of sick patients and people dying there. This is the only advantage I had from the lockdown, spending time with my little one. That's Basil. So just a background, as we know, at the end of 2019, this virus was identified as a cause of a class of pneumonias in Wuhan in China. The virus is rapidly transmissible throughout the world, resulting in a significant global pandemic. This virus causes severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2, and the illness it causes called coronavirus disease or COVID-19. The spectrum of the disease and the clinical manifestation varies in adults from asymptomatic patients, which were detected by routine screening, to mild respiratory symptoms, to a worse spectrum with severe pneumonia with acute respiratory distress syndrome and multi-organ failure. So it's important in terms of the management of these patients to have some tools to assess the severity of the disease. And one of the tools we use is the assessment of the degree of dyspnea. And importantly, when we assess the dyspnea, is to look at the trajectory of the dyspnea and how rapid the progression of the dyspnea is over the course of days. And it's important if we notice that the patient's having progressive dyspnea over a short period of time, because that could be a marker of developing acute respiratory distress syndrome and significant deterioration in the clinical picture. 19% of the approximately 1,000 COVID-19 patients were admitted to Wuhan in China that had rapidly progressive dyspnea. And the average of the dyspnea varies from one group of patients to another. And however, the average days that people develop dyspnea from coronavirus is around 5 to 7 days. And that's probably the marker of where the start of the pulmonary infiltration. Other important tool to assess is the oxygen saturation. So for patients who have hypoxia, which is defined as the SaO2 of 94 or less on room air, these patients in particular warranted evaluation. Patients who have oxygen saturation of more than or equal to 95% on room air, the decision on in-person versus hospitalization, it depends on the other clinical features, as we mentioned, severity of dyspnea, risk of severe disease, and assessments of the overall acuity. So in terms of the acuity, as Professor Alrubaie mentioned, there is features of orthostatic hypotension due to the autonomic dysfunction and arrhythmias, dizziness, falls, hypotension, and change in the mental status from lethargy, confusion, change in the behavior, change in the Glasgow Coma scale. Observed cyanosis and the urinary output is also a marker of overall acuity level. Importantly, when we assess patients with COVID-19 infection, to look at not only clinical picture, but also the socioeconomic pictures and the arrangement at home, and people who have problems lacking the ability to self-monitor and self-report any symptoms may need more intense staff out help in order to adequately manage them at home. Importantly, when we come to the risk assessment of patients with COVID-19, two important factors: old age and the presence of the chronic condition probably warrants more attention, and these are the markers of potential severe illness and high mortality from COVID-19 pneumonitis. And this is a long list of the diseases that can be contributing factors to increase this risk, including cystic fibrosis, thalassemia, underlying active cancer, patients with cerebrovascular disease, chronic kidney disease, which we actually seen a lot in Westmead recently. Of course, patients with underlying lung disease, interstitial lung disease, chronic obstructive airway disease are at risk of further deterioration. People with immune suppression, including type 1, type 2 diabetes patients, HIV, or other immune deficiency, are at risk of deterioration. Chronic heart disease, heart failure, coronary artery disease, and cardiomyopathies are also a group of patients that could deteriorate quite rapidly. Pregnancy, sickle cell disease, and people with obesity, because obesity could be worsened. Obesity can worsen the hypoxia in the presence of COVID-19 infection. So we have outpatient management, and in most cases, in 80% of the time, patients are not severely ill to the state that warranted admission to the hospital or medical attention. And most of the time, this patient can be managed in the outpatient setting. But we have to have a good system in terms of how to manage these patients. And USA have developed a few strategies in terms of programs available to manage this patient, which Australia started to adopt recently. So we have what we call telehealth and remote care. We have in-clinic and management. So, and the rationale of doing outpatient management with remote care is to prevent unnecessarily inpatient medical visit, including visit to the emergency department, avoids unnecessary strain to the burden of the health system, including utilization of limited resources, especially personal protection equipments, and also reduce the risk of exposure to the other patients and healthcare workers. So in-person evaluation is needed probably in the following scenarios: in patients with moderate severe dyspnea, in patients with hypoxia, measures by pulse oximeter, and in patients who have some features suggestive of impairment of acuity level. And this evaluation could be in the clinic or could be in the emergency department, depends on the severity of the above findings. Clinical evaluation in the outpatient setting is probably warranted in patients with mild dyspnea, in patients where the oxygen saturation room is between 91 to 94%, patients with mild dyspnea with risk factors for severe disease, any moderate dyspnea in any patient, and symptoms concerning enough to warrant inpatient evaluation, like mild orthostatic, but not severe enough to require ED referral. So what's the medical therapy available for outpatient settings? To be honest, it's all conservative approach, and there is a lot of studies looked at the different medications, pharmacotherapy for the management of outpatient settings. Monoclonal antibodies, high quality data is needed to support them, and they actually require a lot of resource to administer them. There's no strong evidence of using them in the outpatient setting. Systemic steroids in patients with no evidence of hypoxia and not being hospitalized with COVID-19 pneumonitis. There's no evidence to support any form of glucocorticoid therapy in managing these patients. Inhaled glucocorticoids, there was some trials show some benefits. However, it's a modest benefit and didn't have any impact on the mortality. Colchicine was another drug that was tried, had modest benefit, but the side effect outweighed the benefit of using it. I'm sure everybody heard about ivermectin and fluvoxamine. Very limited data, and there is no recommendation to use any one of these drugs for the management of patients with COVID-19 at this stage, because the trials are very small and limited. Hydroxychloroquine and azithromycin have received a lot of attention as a possible antiviral propensity, but trials also suggested a benefit of these drugs in patients with COVID-19 is very limited. Now, as a general respiratory physician, I've seen a lot of patients with COVID infection with significant hypoxia. We in Westmead Hospital, we have up to, at some stage, we had up to 15 to 20 admission at the minimum in one day. And the criteria for inpatients management is basically hypoxia with SpO2 of less than 94 on room A, tachypnea with a respiratory rate of 30 breaths per minute. The ratio of the PaO2 to FiO2, which is a marker of how severe the disease is, if less than 300. And if there is radiological findings consistent with more than 50% of the lungs being infiltrated with the disease, it's actually a marker of significant deterioration, and these patients need admission to the hospital. The important things when we admit the patient into the hospital, we look at the evaluate this degree of this disease severity and the presence of organ dysfunction. Hypoxia and need for oxygenation or ventilator support are important things to evaluate. And these patients undergo a lot of investigation, including the full blood count, looking at the lymphocytes. Lymphopenia is very commonly seen in this population, but I did see a lot of patients with even neutropenia. We check the kidney function, liver function test, which is very, liver function test range is very common in the course of the disease. Creatinine kinase, C-reactive protein, it's an important marker of disease activity. Coagulation profile, D-dimer, which is a surrogate marker of hypercoagulability in these patients. Lactate dehydrogenase, we actually recommend repeating on a daily basis. Troponin, if there is evidence of myocarditis, ECGs, and we do a full viral screen, including hepatitis B and C, as well as HIV and TB with IGRA or gold quantiferon to basically detect if there is any evidence of serological conversion of these infections in the context of using immunomodulation therapy, the Baricitinib. Chest X-ray is warranted in all patients, and we do serial chest X-ray to monitor the progress. Now, the role of the CT scan is very limited, and in Wuhan, a lot of patients who were admitted with pneumonitis underwent a CT scan of the chest. But if there is no indication to change the management, the CT scan is probably not warranted. So therapies lines are, we know all these patients are at risk of venous thromboembolism, and DVT prophylaxis is preferred pharmacotherapy. There was a study look at the role of full anticoagulation in patients with coronavirus infection to look at the mortality and recovery at up to 21 and the need for mechanical ventilation. And there was some evidence it support the use of full anticoagulation. However, the bleeding risk, as you're probably aware, is high. It doubled in patients who didn't receive anticoagulation. And Westmead Hospital at the moment are running a trial called ASCO trial using modified dose of Clexane in this population. We do non-steroidal anti-inflammatory drugs for fever and other myalgia. Most of the medication the patients on, we advise them to continue, especially aspirin statin, because we theoretically know that this medication, the presence of infection and hypercoagulability, reduce the risk of ischemic heart disease and cerebrovascular disease. Infection control with full PPE. We avoid nebulized inhaler therapy, and we change it to MDI to reduce the risk of aerosolization. And then we have what we call COVID-specific therapy, which is something has grown in the last few months. The first drug was tested is dexamethasone at the dose of 6 milligrams daily. It's highly recommended in patients who have hypoxia and receiving low flow supplemental oxygen. It did show that in this study, which was released in New England Journal of Medicine in February this year, that the 6 milligram daily of either oral or IV dexamethasone improved the mortality in all participants. The best benefit was in patients who had hypoxia or requiring an invasive ventilation. As you can see in this diagram here, the evidence support the use of dexamethasone is high in patients who require invasive mechanical ventilation or oxygenation. The evidence was not very supportive in patients who are not hypoxic. So the take-home message of this study, if patients have pulmonary infiltration, pneumonitis, hypoxia, needing oxygen therapy, they should probably go on 10 course daily of dexamethasone. The other drug that was studied in the management of COVID pneumonitis was remdesivir, which is the antiviral therapy. The study was released in November 2020, again in New England Journal of Medicine, and it did show that if you use remdesivir up to 28 days, it reduced the overall, it increased actually overall recovery time. Again, it did show that it's more effective in patients with hypoxia, receiving oxygen therapy at the flow rate. Interestingly, the remdesivir show no statistically significant improvement in the recovery rate compared to placebo in patients who received high flow oxygen or non-invasive ventilation. So at this stage, what we do recommend is if the patients on low flow oxygen, they should go on dexamethasone as well as the remdesivir. Baricitinib is a JAK1 and JAK2 inhibitor that basically are important receptors to create a pro-inflammatory pathway signaling, and this pathway is overreacted in a lot of autoimmune disorders like rheumatoid arthritis and other connective tissue diseases. And baricitinib target these receptors of JAK1 and 2 and disrupt the activation of downstream signaling molecules and pro-inflammatory mediators. So here we have JAK2 receptors. These are the molecules that activate the receptors. And on this side where we on the right side where we have no baricitinib, if there is activation of these receptors, there will be downstream signaling pathway of all the molecules that are in charge of the hyperinflammatory response, including interleukin-1 beta and tumor necrosis factor alpha, as well as interleukin-6. and that causes a lot of hyperinflammation. In contrast to here, where we have the baricitinib blocking these receptors and overall block all this pathway, overall you end up having a low inflammatory response by reduction in the level of these immunomodulators. Baricitinib is recommended in patients with COVID pneumonitis who are on low flow supplemental oxygen and has significantly elevated inflammatory marker CRP of more than 75 and escalating oxygen requirement despite initiation of dexamethasone. Now, baricitinib, we give it for patients who are not in ICU or not intubated. Tocilizumab, we give it in patients with significant hypoxia and require non-invasive ventilation. And the definition of escalation of oxygen requirement is up to 6 liters per, the flow of oxygen is up to 6 liters per minute, or the requirement of oxygen or escalation in the rate of oxygen therapy via the nasal cannulae. This is again another study which was released recently in NIJM, looking at the role of baricitinib in conjunction with remdesivir in one arm and baricitinib plus placebo for hospitalized patients with COVID-19. And what it showed that if you use baricitinib in patients who have oxygen requirement and especially high flow oxygen requirement, you actually improve the proportion of the patients at the 28 days who recover from COVID-19 infection. So it's an additive therapy to the dexamethasone plus minus remdesivir in patients with hospitalized patients who have significant hypoxia. So the key messages is that outpatient management of COVID-19 is usually appropriate in majority of the patient. It's important when assessing patient to look at the risk stratification, the underlying comorbidities and the tools, including the dyspnea and oxygen saturation, as well as the acuity level, to determine which pathway they're gonna follow, either the inpatient versus outpatient pathway. Clearly, dexamethasone at the dose of 6 milligrams shown improvement in the mortality in patients with COVID-19 who are hypoxic, and immunomodulators, especially baricitinib, have a significant roles in patients with severe disease spectrum who are needing ICU admission plus minus high flow nasal prawns or mechanical ventilation. I think I will stop there and thank you.
Thanks.
Thank you so much, Dr. Fidel. I'm going to move swiftly to our final presenter, and then we'll have some questions. Please put those in the chat or use the hand up function, which you'll find under reactions. There's a little smiley face button. So at the end of this session, yeah, please, if you have any questions, just pop your hand up and we will go to you. So finally, I'd like to ask Dr. Jamal Rifi to unmute and present. That would be wonderful. Are you there?
Good evening. Thank you, Rachel.
We can't see you, Doctor.
I can see you and I can hear you.
We can see you now. Beautiful.
Okay. Okay. Good evening, everyone. Jamal Rifi is my name. I'm a general practitioner in Belmore for the last 30 years. Like many of you, my fellow general practitioners who've been involved in the rollout, I started vaccinating on the 22nd of March of this year, almost 6 months ago. Started at Belmore, and then 7 weeks ago, we opened another vaccination clinic at Chester Hill, at the old Chester Hill Bowling Club. And it took us 5 months to actually vaccinate 10,000 people. And in the last 3.5 weeks, we've vaccinated 5,000. And that's where the demand is is stronger than what it used to be. And tomorrow is Thursday. The day after tomorrow, we are starting the first drive-through vaccination clinic at the Belmore Sports Ground, and that's in association with the Canterbury Bulldogs and the Canterbury Bankstown Council. We have been allocated at our drive-through 1,170 Pfizer vaccine plus the AstraZeneca. That means we can immunize probably about 400 Pfizer patients every day, plus the AstraZeneca. And the Pfizer vaccine, it will last us only 3 days. So that's why we've decided to open on Friday, Saturday, and Sunday, because many people, they're not getting their vaccinations on the weekend. And because they are working for the next weeks. On October, it will be our last day for vaccination. To be honest, I just shared some of my experience that I had during this vaccination, and plus at the same time calls from my patients and who have been affected by the COVID-19. I was called to do a home visit for elderly couple. So I took some of my AstraZeneca, went and visited them, and I said, I've got the AstraZeneca, and the immediate reaction was, no, I want the Pfizer. And said, look, the issue is we need to give the AstraZeneca, but they both have refused. So I actually returned empty-handed. Of course, patients, they have the right to choose which vaccine they have, and I need to talk to them about it. So I ended up going another day, give them both of them the Pfizer they have asked for. Unfortunately, this is very common. We have limited supply of the Pfizer vaccine, and but we need to deal with it. And unfortunately, the elderly patients are still at risk if they choose not to have it. So we need to give them the alternative. That's one. The second, I get some calls, which is sometimes unusual, but I'm going to share them with you. One in particular, a positive patient, young mother, and she was breastfeeding a newborn baby, 4 weeks old. And the question is, look, I've got the Pfizer, I am positive, I'm not that much affected, but can I continue breastfeeding? And look, to be honest, I didn't have an answer to this. So I referred to Professor Booy, and to his credit said, look, she can have actually breastfeeding, she is well, and it's not teratogenic, and there is no issues. So that's the advice. So out there will be asked some questions that we are not able to answer it. So we need to refer to expert in this field. The second thing, which is the most common one for people who have the Pfizer documented positive COVID infection, is when they're going to have their vaccination. And the advice is 6 months from the date of diagnosis. And unfortunately, that advice is not working for people, because if we're going to wait for 6 months to give them their vaccination, they are complaining to me they can't go to work, they can't actually go to places, and that sort of things. Then when I got the exemption form from New South Wales Health, to be honest, all the exemptions form that they are approved exemption, positive COVID infection is not one of them. And that is strange. So I had to write actually a letter and write on the form COVID infection proven and the date and everything, gave it to the patient. He went with it. And unfortunately, actually, he came back to me a couple of weeks later, said, look, nobody's seen these forms. I need to go to work. They're not going to accept it unless I get vaccinated. And these are the dilemma we are facing. And we need to get actually make our own mind about how we can help and assist those patients. Unfortunately, I'm still getting my supply from the Commonwealth. And as I said, for the drive-through, it's 1,200. I'm just talking with the New South Wales Health if they give us more vaccine from their allocated numbers, and so we can open our drive-through for longer hours. Happy to take any questions from you. Thank you.
Thanks.
Thank you so much. And so I'd like to just invite anyone who has any questions to either pop them in the chat or just simply raise your hand and we will go to you. Doctor, did you have any questions for other panelists whilst perhaps some of our attendees formulate questions? I know it's a lot to take in and you've covered such a breadth of topics and overviews. I certainly know at the MRC, I guess we're connected with community and there are so many questions that are still unanswered and varying levels of access. And I think access remains one of the biggest issues amongst the community. So just kind of sharing that with you. And I think Dr. Jamal, you're talking about, you know, getting more jabs in arms, which is going to benefit obviously the community and impacting that number getting to 80% quicker.
I'm happy to field a question.
Thanks, Dr. Booy.
I was asked by Dr. Ahmad about the issue of when you might want to give booster vaccines. And there's been some very interesting papers only published in the last couple of days. And there's been a directive from the United Kingdom that they're going to boost half their population. Essentially, they're going to offer a booster to anyone over the age of 50, anyone under 50 with a chronic medical problem, or anyone living with someone with immunosuppression. So that's about 30 million people. So that's the decision they've taken. The US have also decided to boost people first over 60, as they did in Israel, but some are looking a bit earlier as well. Do we need the booster? Well, there's a very good paper just published 2 days ago suggesting that immunity is very good still 6 and 12 months after COVID infection or COVID vaccination. So it's actually controversial. I don't see Australia rushing into doing a booster before Christmas. I think we'll optimize at 80 to 90% level double vaccine for the population. And we may consider the kind of people who get a flu booster in March, April, May might be the same people in the other arm who get a COVID booster. So people with a chronic medical condition, people over the age of 65, and people living with someone with immunosuppression. So that's my simple answer. I don't see it in any way a priority or a rush. We may be doing it in March, April, May next year. But really the big issue from a world point of view is getting everyone having a first dose, whether they live in Australia or Indonesia or another country.
Thanks, Dr. Booy. We have a few questions, sorry.
We
have a few hands up as well, but we'll come to those questions, Dr. Ahmad.
Yeah, well, look, I might involve Prof. Booy in this comment. Lately, there is a talk of have a special consideration for hotspots in relation to post-COVID vaccination. So there is a talk of reducing this 6-month standard period for vaccination to 3 months in hotspots with the risk of getting the disease even after COVID is higher. Someone talk about evidence, but I don't have the evidence. What's your opinion, Prof. Booy, about this?
Well, firstly, I've just read another marvelous paper. I'm reading constantly because it's so much fun. And I'm semi-retired, so I can do what I like. I am paid 1 day a week, and I really enjoy doing the COVID work. What I've just read is about hybrid immunity, and that comes from a combination of having had COVID and being vaccinated. And it tends to be really strong. So people who've had what's called a breakthrough infection after 2 doses of vaccine, then they get a mild COVID. There are, of course, 90-year-olds who die after 2 doses and COVID, but almost anyone who gets COVID after 2 doses gets it mildly. And that hybrid immunity is deeper and wider. It's really strong. And it's better than vaccination alone or COVID alone. And if you compare the two, it depends on the paper you read in terms of immunity. Some people are saying that 2 doses of COVID vaccination are better than disease. Another paper I just read today said the opposite. So they're probably fairly similar. And if you've had COVID, as you describe, I think any time from 3 months after COVID is an acceptable time to vaccinate, but we should check with ATAGI and follow their guidelines.
Thank you. We have a question specific to patients who have been diagnosed with COVID and are coming out of isolation post-infection and getting certificates. Apparently there are lots of individuals struggling with getting a certificate. Does anyone have any more information? Perhaps Dr. Mettis, do you have any insight to that?
Well, look, in practical term, I had to deal with this issue on numerous times. And if someone who is a proven positive COVID and he's got the results, and the best way is just to download the certificate of exemption and just fill it up, add some comments to it, write a letter with it, and just give it to the patient. And we need to wait at least, as Professor Booy said, it's actually 3 months after the infection to be able to give them their vaccination. There is no other way around it.
Can I just say something? So basically, patients, in terms of the de-isolation or discharging from the hospital, I mean, what we do in the hospital setting is if the patient has 2 PCR negative for COVID-19, or if they have a culture which is negative, then that should be, or if they have, if they 14 days post recovery of the symptoms, they probably should be de-isolated. And they don't need ongoing isolation. The PCR can stay positive for a long time, as long as the culture is negative. Then, because the PCR will detect the dead virus, but the culture, it should not be positive on the culture.
Thank you, doctors. And we have quite a few questions now, so I'll take one more from the chat and then we'll go to our individuals who put their hands up. And so another is around opinions about combination of vaccine types. I know this is a common question.
Can I answer this?
Yes, please.
Yep. Look, there is a definite evidence by several studies from Germany and from UK in liaison with Spain and Germany, that the second different dose, the dose of a different vaccine, create more immune response than the second dose from the same vaccine. So if we start with AstraZeneca and we give them Pfizer, then the response to this dose is much more if we give a second dose from AstraZeneca. And likewise, if we start with the Pfizer and we give AstraZeneca as second dose, then the response is much higher. So there is a good evidence about it. And this is probably more than a few months.
Look, that is correct from the medical point of view, but unfortunately from the practical point of view, it's very difficult for the patient. Everyone will ask me to give a different vaccine, a mix and match. The issue is when we try to obtain their certificate about the vaccination certificate, if we give them one AstraZeneca, one Pfizer, then the certificate will come actually vaccination incomplete. And that is from the Australian government, Australian Immunisation Register. What happened is if we give them 2 Pfizer or 2 AstraZeneca, then the certificate comes with complete and with a tick. But if you give them 1 AstraZeneca and 1 Pfizer, then becomes actually certificate incomplete with an X. That is the practical aspect for it, because we all know medically exactly what Dr. Alrubaie have said in terms of the papers, but unfortunately, the Australian website, the Australian Immunisation Register, they haven't approved that as a complete certificate as yet. So there is that practical aspect. We need to be wary and tell patients about it.
Thank you so much. I think we're waiting for the systems to catch up with the advice perhaps. I'll move to Vani. So you've got your hand up, and then Dr. Bushra afterwards. So Vani first.
Okay, thank you. I've got a couple of questions. First is, Dr. Mettis mentioned outpatient assessment of COVID positive patient via telehealth. I have a lot of doctors who are interested in volunteering their services because I understand the system is stretched. So we just, if there's a way to link us with relevant health services, that'll be great, whether it's Southeast Sydney Local Health or Western Sydney. We have doctors in all areas who are interested. So we're having trouble getting people through admin to reach the support. Secondly is the question to Dr. Booy, Dr. Rifi, and Dr. Ahmad. I have a lot of patients with COVID who have long COVID. And I understand the vaccine is a prophylaxis to it. So therefore, would it be an idea to vaccinate people who want the vaccination? That's my question.
Thanks, Arnie. Who would like to take?
It's a little, could you repeat the question? I'll try and answer it.
So I understand there's evidence that long COVID, the prophylaxis for long COVID is vaccine, because I have a lot of patients with COVID and long COVID symptoms. They've been 4 weeks post-infection, and they have all the things that Dr. Alrubaie mentioned in the long COVID. So would it be advisable to vaccinate these patients so they don't suffer for an entire year with it?
I don't honestly know the answer to that. I'm a pediatrician, and I can tell you that the long COVID that occurs in children is much less common. I know that. Whether giving a vaccine to someone who has symptoms of fatigue and the like to try and prevent long COVID, I don't know. Maybe one of my colleagues can answer that better.
Can I answer? Look, I presume you're talking about post-COVID, correct? We're talking about post-COVID there. We said the immunity by COVID-19 is not long-lasting, and we talk right now about a period of 3 to 6 months. It is not advisable to have the vaccine earlier there. So I don't know on which period you're talking about. We said post-COVID, all will need the vaccination in 2 to 3 months. And this will help in probably reducing the long COVID symptoms. But earlier than that, to prevent the long COVID, I don't think this is proven by any evidence.
Okay. And Dr. Mettis, about volunteering doctor services for outpatient?
I believe there is in Southwest Sydney as well as Western Sydney, I think they're establishing new telehealth services for all the majority of them are respiratory physician as well as infectious disease people. Yeah, I'm not sure how technically that would be possible, but I think that the program is starting soon in the hospital setting from Liverpool and Westmead. We surely do have. We actually don't have a good strategy of how to manage this patient long term, especially people with residual pulmonary fibrosis, what to do for them, how to monitor them, what therapy will apply for them. And I think in the next few months, we will have more insight into what monitoring program we should do for these patients.
Thanks, Dr. Mettis. Next question is from Bushra.
Yes, hi everybody. Are you hearing me?
Yes.
Yes.
The question is to Professor Booy. It's about the immunization, as he is like an expert in immunology. So my question is, what's going on, guys, in England and in Israel? There is a very high number of people vaccinated, about 78 to 80% of people are vaccinated. I was talking to somebody, one of my colleagues in England. She said there are hundreds of thousands of cases in England. and their NHSC, like the health system is like, it's not coping. So does that mean the vaccine is weaning, or it's like, it's not working no more, like the vaccine working? What's the reason in your opinion? Is the Delta virus is resistant to the vaccine, or what's the reason for that hundreds of thousands? Because people keep asking me if Israel was the first like country in the world,
please stop.
And they are suffering now. So what's the reason? Thank you.
You've got a very jaundiced view. The truth of the matter is that most severe cases remain in unvaccinated people, and Israel and United Kingdom have probably around 80% double vaccinated, and most death remains in unvaccinated people. So please don't catastrophize. I seem to have to say that every day. The truth of the matter is not that there is hundreds of thousands of cases. There's colds, and the UK used to have many thousands of deaths a day. It currently has about 100 deaths per day. That's not good, but it's largely in unvaccinated, or if they're vaccinated, it occurs in people with immunosuppression. Yes, it's true there is waning immunity, but that's to infection. So far, for severe disease, hospitalization, intensive care, death, we retain high levels of protection in the UK and also in Israel. Now, Israel has primarily used Pfizer vaccine, and they are finding that the antibody response after 6 to 9 months is declining. But our immunity is based on a lot more than just an antibody concentration. We have B cell memory, we have T cell memory, and that continues to protect people in Israel and the United Kingdom against severe disease. So if you look at the graph, there is, yes, high levels of infection like you get with influenza or with rhinovirus or with adenovirus or parainfluenza, but there are not high levels of disease anymore. 100 deaths a day sounds bad. Well, the UK normally in an influenza season has 10,000 deaths. We have 3,000 from influenza, and it's generally over about 100 days. So 100 into 10,000 is 100 deaths a day from flu over a 100-day period during winter in the UK. So it's not nearly as bad as your colleague is suggesting. It isn't straightforward, and it's likely that the waning immunity in a year from now or 6 months from now will mean that it's a good idea to have a booster. But it's not proven. There's a lot of debate, and a lot of experts are saying, well, you've still got good protection, and they're not certain that you need the booster. And, you know, I don't believe in conspiracy, but, you know, the drug companies like to sell vaccines. So you have to take a moment to say, are these people really getting sick and dying, or are they just getting a cold? And the truth is mostly in the field of it, they're just getting a cold. And if 100 to 150 people die of COVID a day in the UK, that's not many more than would normally die from influenza in a winter season. So it is worse than influenza at the moment, but maybe in a year or two from now, the death rate from COVID will be much closer to influenza. Not yet, but it's getting that way. So please feel reassured. I think we may well be into boosters next year, but there's no dramatic pandemic coming our way, in my opinion.
That's good. Thank you.
Thank you.
Optimistic.
Yeah.
Optimism is good.
Just a simple addition to what the Prof. Booy mentioned about this. Can I just add that the data from state confirmed that this wave of increasing cases there is mostly among children and young people who are either either not vaccinated or haven't had the disease, unlike other. So the current wave is in people who are unvaccinated, particularly young people. Thanks.
Yes.
So, and just to, I guess, add to the question, there's a question in the chat that I think.
Oh, Rachel, the whole
phase.
time you've been too quiet. Can you turn your volume up?
Yes, yes.
Oh.
She's very sorry.
I can speak louder.
That's better, Rachel.
There's another question that talks to, I guess, the expectations or otherwise of another outbreak, and specifically the Mu variant. Is that likely? Is that expected?
Let my colleague answer first.
Can I answer? Well, look, this depends on the rate of controlling this pandemic, not eradicating, controlling. The higher the number of cases, the higher chances of developing a new, more aggressive variant. And that from the experience. All these variants appeared late last year with the increase in the numbers in those epicenters. It was United States, United Kingdom, South Africa, Latin America. You can see most of them. So I think this will depend on the rate of controlling it. The more the number, the higher chances of some of these mutation will be of more favorable response for the virus, which make it more surviving against vaccines and against our immune system. And that's why we heard about the Delta Plus and lately about the immune variant. Thanks.
And I'll add to that. I talk to a virologist almost every day. I'm not one myself, but I do virology reading and talk to virologists. Delta is incredible, and I think Professor Ahmad and one of the other professors has said, in every continent, the number of cases that are Delta are between 95 and 99%. It has taken over. Wuhan strain is gone, Alpha strain is almost gone, and the new Mu strain, which is B1621, is only in 1 in 1,000 or 1 in 100 people. So it's not yet becoming common. So Lambda, only in parts of the world. Look, Delta has taken over. It seems to be the fittest. So on a positive note, I don't see a new variant yet. Of course, a new one will come. But one of the trends in virology is if it gets more transmissible, it may become less virulent. Now, that's not a certainty. The virologists tell me it could go either way. So I'm not going to be a super optimist and say the next variant will be milder, but that's one way that virology turns out. That's one way that virology evolution can occur. So we don't need to expect a worse variant next. It may be more transmissible, but it may be only as virulent or less virulent. We just don't know. That's the honest answer, and that's talking to the best virologists I know.
Thank you. Now we're due to finish at 8 o'clock. We do have probably another 7 or so questions. How are our panelists feeling? Are you willing to answer a couple more?
Yeah, I've preferred to extend it 5-6 minutes. It's all right.
Okay, beautiful. So there's a specific question too. I'm just scrolling up with the many questions. Specific to giving the Pfizer vaccine to patients with sickle cell anemia, or thalassemia major, or those that are allergic to the flu vaccine. Would somebody like to take that?
I'll take that quickly, not a problem.
Thank you. Okay, thank you.
Just one simple addition, that they probably are a bit higher rate of complication, but it's strongly indicated. The vaccine in sickle cell and hemoglobinopathy is highly indicated, but that one should be cautious about some higher complications. Yep.
Okay, thank you. There's quite a few questions relating to being post-infection, being asymptomatic, and just symptoms in general. So I'm going to try and cover those off in a series. If a patient is a close contact with and has symptoms of COVID-19, but has a negative PCR, and the patient continues wanting to be checked, can an antibody test be ordered to definitely kind of rule out? So ongoing symptoms,
So I think,
negative
yeah.
tests. Yeah.
So I think to answer this question, the options are to repeat the PCR again, or to do the viral serology culture. That's other options if somebody's got ongoing symptoms and negative first testing. So just to repeat the test, keep isolation until until the symptoms completely resolve, or do the test by doing the PCR or the culture.
Okay. Look, I'll just give an example in here. These symptoms actually should be treated. They are as a positive COVID unless proven otherwise. I had patient that's actually they've done PCRs in the morning that came back positive, but on the same day they went somewhere else and did a PCR that turned up negative. What happened is PCR is operator dependent. We need to be very careful. There are a lot of people out there that do this swab, but they may not collect a good swab. So if this patient has done the PCR, it is negative but has symptoms, we should not trust one PCR. Should treat them as a positive patient. They will repeat the PCR and then we'll do the viral cultures or whatever. But doctors, they are very reluctant to see patient with symptom with one PCR that is negative.
Thank you, doctors. The next question in relation to the infectious period. So how long can a positive infectious person shed the virus? And in relation to contagiousness, is that via skin or is it just airborne, both, one or the other?
Well, I just mentioned that in Delta, the shedding period is longer than in other strain, particularly the original Wuhan one, and it can extend up to 18 days instead of 12 to 14 days. And in immunocompromised patient, this period can extend up to 20 days. So that's the period of shedding. I think contact, in addition to droplet and aerosol, is a source of infection. That's why dealing with the surfaces, contact surfaces, is important to clean them and maintain hygiene.
And there's another question again that's a follow-up to that. So if somebody is infectious and has gone through isolation and then I'm going to assume that they're having a negative PCR, but they still have symptoms, is there advice in that instance?
So they have COVID symptoms, you mean?
They've been tested positive, they've been in isolation, I'm assuming they've tested negative, but they're still then having symptoms. Is there any advice either way there? Do they need to be retested? Should there be a double kind of negative PCR? Or, are there any strategies that you would advise on?
Look, my impression is if they're still having symptoms after they've gone to isolation and tested negative, they're most likely still having the symptom of the COVID, but without carrying the virus itself. But that is actually what, if it stays like this, then we call it is actually long COVID. It is very common when the virus will go. It doesn't mean the symptoms are going to disappear overnight. They will still need to be treated. They're not infectious to the others, but they will keep having the symptoms as a consequences of the infection without them being infectious at that time.
You can do either another PCR to confirm 2 negative PCR, or do the culture to confirm the resolution of the viral activity.
Thank you. There's a question specifically for Dr. Booy in relation to giving consent for children to be vaccinated, and that parents are often asking, what is the aim of the vaccine? Is it, benefit for the kids, or is it benefit for society, or perhaps both?
Yeah, great question. Children can give assent, they can say they want it, but they should have their parents' permission. And what are the benefits? Well, there are marginal health benefits in favour of vaccination because you're not preventing much in the way of severe disease in teenagers, but there is some health benefit. But the second and the third are exactly as you referred to. The social and educational benefit of getting kids back to school. Getting kids back to school is incredibly important for their mental health, their physical health, their education, and Gosh, did I say mental health? I did. At the moment, the decision that's just been taken in the last 2 days in the United Kingdom was to go over the JCVI. The JCVI is a bit like a TAGI. It originally said only high-risk kids with chronic medical conditions get vaccinated. And then within a few days, the chief medical officer changed the recommendation to all children 12 to 15 because of the social and educational benefit over and above the health benefit. Now, the health benefit, as I explained in my talk, arises because half of the children who get severe disease have got a chronic medical problem. And the best way to vaccinate and protect people with chronic medical trouble is to actually take a universal approach. In childhood, we prevent all of the nasty complications of measles and chickenpox by vaccinating all children to prevent the few children who will get it severely. Half of them get it severely because they've already got a chronic medical problem. Half of them are actually well, and we have no understanding and no idea as to why a well child would get severe life-threatening measles or chickenpox, or COVID for that matter, that they're the exception, and we vaccinate universally to prevent that.
Thanks very much, Doctor. There's a couple of questions just in relation to vaccination coverage and also vaccination in relation to helping in all variants. So for question one is, are we sure that all COVID cases in Australia are only the Delta variant? And the second adjacent question is around vaccination covering all variant types, and specifically, is Pfizer vaccination cover other variants as well?
You to answer? I think this wave is a Delta wave that we can say that it is dominating. There are some report of some Kappa variant, few cases in Victoria, in Melbourne, but nothing other report I come across. Probably Prof. Booy might correct me on this. The current vaccines work on the all variant. Well, if we're talking about Delta, they have almost the same efficacy as with the Wuhan version or other one. So that's the good thing about the current vaccine.
Yeah, I agree. The beta looked problematic, but it went away, so we don't have to worry about it.
Thank you. And then there are three questions in relation to pregnancy and infertility. So one specifically asking around vaccine safety for pregnant women, one relating to infertility related to vaccination, and a third question asking about the AstraZeneca safety profile in pregnancy as well, and is that less because of blood clotting?
So I'll take that. Yep. First of all, before you're pregnant, getting the vaccine does not reduce your fertility. And that's been shown in many millions of women in North America. Then pregnant women, again, many millions have been vaccinated. Remember, I showed a slide that 4 million children are born every year in the United States. That's the birth cohort. So already many millions of women have been vaccinated while pregnant. The baby has come out just fine. So there's been no detriment to the baby, no detriment to the pregnant mother. And as for AstraZeneca, because most of the experience in pregnant women has been in North America, the preferred vaccine for pregnant women is Pfizer. When there's more real-world experience coming from the United Kingdom, for example, and we have better real-world data, then we can make pronouncements about Astra. But for the moment, the preferred vaccine for pregnant women is Pfizer.
And is there any information specifically to if somebody has had an AstraZeneca vaccine and they're planning to be pregnant, what that time frame or window should be before actively trying?
So the UK has given tens of millions of people both Pfizer and AstraZeneca, including lots of pregnant women. I'm not aware of any issue.
Thank you. There's another question specifically to hospitalization and treatment, in specifically the use of antibiotics, whether that's the type of patient, the type of antibiotics, dosage, and yeah, longevity.
So in terms of the antibiotics for COVID pneumonitis, I don't think there is any role of covering patients with COVID pneumonitis with antibiotics, unless there is a high index of suspicion there might be superimposed infection. We did have some patients who we think radiologically and clinically they behave like more sort of consolidation due to bacterial pneumonia. And in this population, in the presence of radiology or culture results, there is a role of antibiotic therapy, but routinely we don't use antibiotics. And the guidelines for antibiotic therapy follow the ETG guidelines in terms of managing community-acquired pneumonia. It depends on the pneumonia severity index. So BenPen or penicillin plus doxycycline in mild cases. In severe cases, basically third generation cephalosporin, which is ceftriaxone plus minus azithromycin. In patients who are intubated, we usually try to cover for ventilation associated pneumonia with gram-positive and gram-negative, so vancomycin plus minus tazocin. So, but there is overall patients who present with pneumonia and they've got ground glass changes or got infiltration in the presence of COVID pneumonitis, antibiotic is not indicated.
Thank you. And we have one last question in relation to safety profile of AstraZeneca versus Pfizer with children's vaccinations. I'm assuming that's for Dr. Booy.
Yes.
I'll answer that quickly. The trials in AstraZeneca were done mostly in adults aged 18 and above. There was a trial started last year in children, but when the thrombosis issue came up, they halted the pediatric trial. And so we don't have the results of that study yet. And so the only real experience we have in children under 18 is with either Pfizer or Moderna. And Moderna is about to be licensed, or it has been just licensed for 12 to 15-year-olds in Australia, and it will be given through pharmacies very soon. So we can only use mRNA vaccines in children under 18 because that's what the license allows.
Great, thank you. Unless there are any last statements from our panelists today, that shakes of heads.
Can I just pass my thanks again to our guest, Prof. Booy, for his great contribution, and for Dr. Mettis and Dr. Rifi for their excellent contribution. Thank you very much again, and thanks for your time.
Rachel, can I just mention something? I think that now we are facing the pandemic and the increasing numbers of patients with COVID-19, but I think the next struggle would be how to manage this patient long-term, especially in patients with significant pulmonary destruction from this virus and pulmonary fibrosis. We actually don't know we don't know how to manage this patient. There's some evidence rising about monitor them with the pulmonary function test and CT scan. There's some studies looking at antifibrotic therapy in these patients, but there is no data available. So I think the main struggle in the future, looking to the future, would be how to manage patients with significant pulmonary fibrosis from this disease.
Thanks very much, Doctor. Well, I'd like to thank you all, our panelists today, and everyone that's taken the time. And we've been online for almost 2 hours, or just over 2 hours. So I want to thank you for your dedication to community, and that the Health Professional Network are crucial to us moving forward and getting through this. On behalf of Western Sydney Migrant Resource Centre and all the panelists today, I'd like to thank Dr. Ahmad for allowing me to facilitate today. I'm ex-health, so yeah, it's good to be connected with you all, and please stay safe and well, and take care, and we'll see you at the next session.
Thanks a lot. Nice having you. Thank you very much, guys. Thanks.